So hello to everybody. Good afternoon. Welcome to this ERKNet webinar. My name is Francesco Emma. I'm speaking from my office in Rome. As always, before starting, I remind you that your microphones are turned off, but that during and after the webinar, you can send your question through the GoToWebinar application that appears on your screen. I will ask your questions at the end of the presentation. The webinar will last approximately 40 minutes, and we will have about 10 to 15 minutes available for questions. So our speaker today is Professor Dieter Haffner. Professor Haffner is Professor of Pediatrics, and he's also the head of the Department of Pediatric Kidney, Liver and Metabolic Disease at Hanover Medical School. He also coordinates in the same institute the Center for Congenital Kidney Diseases. His main interests are the genetic and mechanistic explorations of rare kidney diseases and mineral and bone disorders in children with CKD. He is the president of the European Society of Pediatric Nephrology. He's a counselor for the International Pediatric Nephrology Association, and he's a speaker of the Working Group of Immune Glomerulopathies of the European Network for Rare Kidney Disease, ERKNet. In recent years, he has chaired the IPNA Best Practice and Standard Committees, the IPNA Publication Committees, the ESPN CKD-MDD Working Group, and the ERKNet Guidelines and Pathway Task Force. He has led or have been involved heavily in several randomized controlled clinical trials, patient registries at the national, European, and international clinical practice guidelines. Professor Haffner has published more than 250 original scientific articles, reviews, editorials, and book chapters. And the title of his talk today is Rickets and Osteomalacia in Children and Adults. Please, Dieter.
Thank you very much, Francesco, and I apologize for the long introduction. Since I'm getting older, it's always getting longer, I'm afraid. So, rickets and osteomalacia in children and adults, and oops. So these are my disclosures. And if you want to sleep now or fell asleep, don't mind. You can look up everything in 3 papers. They are all open access. In 1, 2 in pediatric nephrology, it's about ricket guidance. It's a lovely paper done together with pediatric endocrinologists, and then the XLH guideline, which is currently getting updated. So the outline is I will start with a case. I will ask you some questions. Then we will talk about the definition of rickets, and causes and treatment of calcipenic rickets, and then of phosphopenic rickets. So let's start with the child. She's a girl, aged 6.6 years at the time of diagnosis. She was short, and she had a low weight with a normal target height, and her height velocity was also low. If you look here, she was steadily decreasing, and please be aware the 3rd percentile is here. So she's really 2.7 standard deviations below the normal range. And she had some bone findings, which you may depict here. And clinically, she was diagnosed with Genua valga, and there was a negative family history with respect to bone disease. The lab results: elevated alkaline phosphatase, PTH normal, phosphate lowish, calcium normal, magnesium normal, 25 level, it's borderline, also 125 borderline, and then other values like creatinine, thyroid hormone levels, and IGF-1. This was done by the endocrinologist for workup, and also transglutinase antibody. In urine, phosphate 4.4 millimole per liter, creatinine 1.3 millimole per liter, calcium 1.3, and then TMP over GFR reduced and rather low normal TRP, and the urine was unremarkable with respect to glucose, protein, and also amino acids. And the initial renal ultrasound was also unremarkable, especially there was no nephrocalcinosis. So the colleague said, well, it's probably a spotted case of X-linked hypophosphatemia, and started the patients on oral phosphate salts and calcitriol. And within a few months, there was a normalization of alkaline phosphatase. Serum phosphate was still a little bit lowish, about 1 millimole per liter, and the girl showed catch-up growth. So everything looked fine, but then the colleagues also made mutation analysis for the PEX gene. This was negative, and they also thought about tumor-induced associated osteomalacia, and there was also workup which was also negative. So after 6 months, the colleagues made a kidney ultrasound, and this showed profound severe medullary nephrocalcinosis, and the urinary calcium creatinine ratio was also markedly elevated. So the question to you is, what's wrong and how should we go on? This is not a poll question, so I could kindly ask people to speak up. What do you think?
Oh, Dieter, I didn't tell you that people cannot unmute themselves. They can only like write in the question.
Put in the chat. Can I put in the chat?
So yeah, if you want to comment on this case, you can use now the question box.
We just made a few seconds because this is important. And I go back one slide, and we give them 1 minute. Francesco, you see the answer, right? The chat.
In the chat, we just have one possible answer is probably false genetic mutation.
Okay, so it's probably still XLH.
Yeah.
Okay, any other comment?
No.
Okay, so I was quick. I apologize for that, but hypercalciuria was present before start of treatment, and this was the mistake which sometimes happen. So the colleagues measured phosphate, creatinine, and calcium, but no one calculated the ratio, which is about 1.0. This is also markedly, this is significantly elevated calcium creatinine ratio, which is never the case in XLH, and this is not profound, but the 125 level was also slightly elevated. Usually in XLH patients, it's rather low because FGF23 suppresses 1-alpha synthesis. So a patient presenting with hypophosphatemic rickets and hypercalciuria and rather elevated 125 levels is always a good candidate for a hereditary hypophosphatemic rickets. And I didn't show you the FGF23 levels because this would be too easy. They were just in the normal range. And so after calcitriol was discontinued, hypercalciuria was normalized, and the mutation analysis showed mutation in the sodium phosphate cotransporter SLC34A3, which is, and so this patient has obviously a different diagnosis. So the take-home message for you is, in every patient you suspect XLH, make a simple, cheap test, check calcium creatinine ratio. If this is elevated, it will never be XLH. So now coming back to rickets and osteomalacia. So the etiology are alterations in calcium and phosphate homeostasis, resulting in the end in hypophosphatemia. And hypophosphatemia is the denominator of all forms of rickets. So it results in an impaired mineralization of the cartilage matrix surrounding the apoptotic chondrocytes, and more important, the apoptosis is impaired of the hypertrophic chondrocyte. And this final step heavily depends on the presence of phosphate. So if you have not enough phosphate, you will have no apoptosis of these hypertrophic chondrocytes, and what you get a widening of the growth plate in the long bones. And it always comes together with a mineralization defect also in the bone, which we call osteomalacia. That means children with rickets have always osteomalacia, and adults always have, since they don't have anymore the growth plates, they present with osteomalacia only. In the end, the clinical findings are soft bones, bone pain, leg bowing, and pseudofracture, which only happens in adults. So the diagnostic approach to rickets is clinically defined very easy. You have clinical features like leg deformities, waddling gait, muscle weakness, short stature, and then you have a radiographic finding with metaphyseal fraying and widening of the growth plates and leg bowing. And then biochemistry is changed that alkaline phosphatase levels are increased. So you have an increased osteoblast activity. And then the diagnosis is there that the patient has rickets. It's not easy to always say that the levels of phosphates are really decreased, because you have to know that phosphate levels heavily depend on age and also on sex. These are reference values for boys and girls here. This we just coined together in the Hanover reference study, and you can see that TMP over GFR also heavily depends on age, and especially in the first 2 or 3 years. So if you check a patient, please make sure that you have adequate reference values. And there's always the question if the patient must be in the fasting state, and usually the patient are supposed to have hypophosphatemia, and if the patient has eaten something and the phosphate is still low, then you got the diagnosis. So for the first analysis in the child, especially in a young child, you do not need them to show up in a fasting state. And please remember that in all more recent reference studies, like our study, also from the Caliber reference study from North America, from Toronto and Canada, they never ask the subjects to be fasting. So these studies include patients in fasting and non-fasting state. And here you can also find the calcium creatinine ratio. You please remember the patient we just had a ratio of 1, and it was age 6 years. So this would be here. So this patient was elevated. And it's also nice that you can look up the phosphate creatinine ratio. And if you want to differentiate rickets after you established all the clinical stuff here above, it's always the question, is it so-called phosphophenic rickets or so-called calcipenic rickets? And the denominator is PTH. And if PTH is elevated, and if I mean elevated, I mean really elevated, 2, 3, 4, 5, 10-fold elevated, then it's definitely a calcipenic rickets. If it's norm or minimal elevated, then it's called a phosphopenic rickets. And the most common cause for that is, of course, vitamin D deficiency. And I will not go into more detail here with the workup in the vitamin D levels. I will go strictly to the findings, to the lab findings. These are all causes of calcipenic rickets, and I just highlight the main findings. So you have markedly elevated PTH and markedly elevated alkaline phosphatase. These are much higher than compared to patients with phosphopenic rickets. And since it's calcipenic rickets, you have a tendency also for low calcium, but this could also just be at the lower normal range. And phosphate could be normal or decreased depending on the time of investigation during the course of the disease. And there are different pathogenesis, which I briefly, okay, I can just see. So you can't differentiate usually the patients easily by lab parameters, but sometimes the patient presented with alopecia, then it's clear that it's a vitamin D receptor defect 2A. So for the pathophysiology, for nutrition rickets, we have on one side reduced synthesis of vitamin D, maybe due to reduced sunlight exposure, indoor living, and also patients may have also lack of food rich in vitamin D supplements. And this is often combined also with a low dietary calcium intake. So it's called nutritional rickets due to vitamin D deficiency and or calcium deficiency. And both in the end results that you have a drop in serum calcium, and the PTH, the parathyroid gland, takes care that calcium is normal, because otherwise you get problems with your heart or you get tetany. So the parathyroid hormone gets stimulated, and this has several effects. One, PTH stimulates osteoclasts to mobilize calcium, to increase calcium in the blood, and it also increased calcium absorption by increasing 1-alpha hydroxylase in the kidney, and it also reduces the calcium excretion in the kidney, but you have to pay off. That means that you have an increased phosphate excretion, you have a phosphate wasting, and if you have a phosphate wasting, then you have hypophosphatemia, and then you get rickets, because phosphate is necessary for normal mineralization. And if this mechanism fail, that means you have a complete demineralization of the bone, nothing left, then you get profound symptomatic hypocalcemia, which may even can cause a death due to dilated cardiomyopathy or tetany, and also neuromuscular irritability. Treatment is quite easy. So you can give a native vitamin D in these amounts or one single shot. Please remember, you should always combine it with adequate calcium, and if the child is not eating well, you may start even with calcium supplements. If you only give vitamin D and the patient is totally calcium deficient, you may run into tetany. Now we come to the more funny and rare diseases. That's the vitamin D dependent rickets type 1, 2, and 3. You have here the vitamin D synthesis. So you have from sunlight vitamin D or from diet, which are in the end the calciferols, which get modified by the liver in calcidiol, and then the 1-alpha in the kidney produces calcitriol, which could be degraded in the kidney also, and then acts on the vitamin D receptor, which are more or less in all cells of the body. And in the kidney, it enhances calcium reabsorption. In the abdomen, intestine, it increases calcium absorption, and then it also increased osteoclastic bone reabsorption. And there are 3 defects. One is the 1A, it's the defect where the 1-alpha hydroxylase is not working, so you don't get in the end calcitriol. The second is that the liver is not doing the job, so you have low calcidiol. And the next steps are vitamin D receptor signaling defects. These are the most poor patients with profound hypocalcemia, very, very tricky to treat. And this is an ultra rare disease where you have an increased degradation from calcitriol. I think there are just 2 or 3 patients published in the literature. So if you have a patient where the 1-alpha is not working, you just substitute calcitriol. If the patient has the liver doesn't do the job, you just give calcidiol in these doses. If the vitamin D signaling is defective, then the patients get ultra high doses of active vitamin D. And if the degradation of 1-alpha is increased, then you give just high amounts of native vitamin D. And again, please remember, patients may need calcium supplementation at least at the beginning and adequate calcium intake later on. So we move forward to the phosphopennic rickets. And the first step, if you have normal PTH in such a patient, just measure the urinary phosphate creatinine ratio. And if there's almost no phosphate in the urine and the patient has hypophosphatemia and rickets, then the kidney is probably not the link to the disease, but rather the patient has insufficient phosphate intake, malnutrition, has some gut problems. So please check this at the beginning. If you measure TMP over GFR with the formula gives you a false reduced TMP over GFR, because the formula is always the phosphate levels minus a ratio, and then the ratio, there's the urine and the serum value included. But if the serum phosphate is already totally reduced because your patient doesn't get phosphate from the gut, then the TMP over GFR is falsely reduced. So, but you can just check the phosphate creatinine ratio in urine. And if this is not the case, then the next step is to differentiate between patients who have an FGF23 mediated and those who have a non-FGF23 mediated disease. And the most common FGF23 mediated hereditary disease is the X-linked hypophosphatemia. It's with dominant inherited, as well prevalence of about 2 to 4.8 per 100,000. Patients have, most patients have a mutation in the PEX gene with the consequences of elevated FGF23, which causes renal phosphate wasting on one hand, and also on the other hand, reduced 125 synthesis, which also promotes hypophosphatemia. Main symptoms are rickets, disproportionate short stature, osteochondromalacia. There are two ways to treat. One, the so-called conventional treatment, which is just nicely illustrated here. So you have a loss of phosphate. You just give lots of phosphate in the body and you give lots of active vitamin D. The problem with that is that you have ongoing loss of phosphate. So if you give high amounts of phosphate, it's immediately within a few minutes or half an hour or 1 hour lost in urine. So you have to give it many times a day. And that may also cause why it's limited efficacy, and you may have side effects like nephrocalcinosis and hyperparathyroidism, because if you give phosphate, you stimulate the parathyroid gland. So this is the limiting of this. And there's now a treatment modality available in Europe since 2018 and 19. It's an antibody against FGF23, which is called burosumab. So you block FGF23 in the circulation, and then you have no more active FGF23 because it's circulating in the blood, bound to the antibody, and this pathway is blocked, and the patient gets healing of rickets. And there was a randomized trial showing that conventional treatment is less effective than burosumab treatment. I will not go today more in detail with XLH because there will probably be a webinar in late this year when the new guideline came out. So I have a question to you. I was talking about FGF23 levels, and so I have a question to you about the value of FGF23 levels in the diagnosis of XLH. So which statement is correct? Only one is correct. A, determination of plasma levels of FGF23 allowed to prove the diagnosis of XLH. B, non-suppressed plasma levels of FGF23 support the diagnosis of XLH. C, plasma levels of FGF23 in the normal range exclude the diagnosis of XLH in untreated patients presenting with rickets and hypophosphatemia. And D, intact FGF23 plasma levels are usually increased in patients, pediatric XLH patients, prior to therapy. Is it running?
Yes, it's running. You will.
Yeah, I wait another 30 seconds so that people can think.
Yeah, that's fine. It's not easy. I didn't make it easy, like always. I apologize.
No.
So another 5 seconds. Okay. Dieter, can you see the answers?
Yes. So
okay.
I think, yeah. Okay. So I'm happy with the results. So the correct answer is B, and I will explain it to you why it's B. Maybe you were not aware of the most recent paper, and I will inform you about that. Oops. Okay, so there's a nice study from Hartley, and they investigated several patient cohorts with FGF23 mediated disease. They were genetically proven, or with tumor-induced osteomalacia, it was clinically demonstrated that they had a tumor which had to be removed. And they looked for the sensitivity and specificity of FGF23 intact and C-term, and you can see here there was a 100% sensitivity and specificity for the level of FGF23 of 27 picogram per milliliter to differentiate between FGF23 mediated and non-mediated diseases. There was an overlap for C-term FGF23, and this is not nicely shown here. So patients with FGF23 levels above 27, they are likely to have FGF23 mediated disease. Below is FGF23 independent. So 27, what is 27 picogram per ml? They didn't know because they didn't evaluate reference values, and this is just the reference values which just came out a few months ago. From the HARP cohort, where we checked the normal range, and you can see here, if you fill in the 27, you can see that it's just in the lower normal range, and in older patients, it's just the around the third percentile. So that means the value of 27 corresponds to the third up to the 12th percentile, depending on age. That means a level in the low normal range may even be compatible, but if you have a level clearly below the normal range, then it's never XLH. So you use it for exclusion, and I summarize this here, that non-suppressed plasma levels of FGF23 support the diagnosis. And the cutoff value is 27 nanogram per ml, but you have to make sure that it's the immunotopics assay. So why is it not definitive diagnosis of XLH? Because there are many other forms of hereditary forms of hypophosphatemic rickets. Is the autosomal dominant and autosomal recessive. You may depict that you have a recessive trait for these forms, and here you have a dominant trait. And the other thing is that autosomal dominant hypophosphatemic rickets often show up lately in adolescents or even in young adults. Biochemically, you can't not differentiate. They have all alkaline phosphatase elevated, phosphate elevated, and PTH is somewhat normal or slightly elevated. So what about the pathogenesis of autosomal dominant hypophosphatemic rickets? Here it's the degradation of the FGF23 protein impaired, and if someone has iron deficiency, then usually the transcription of FGF23 is increased, but the cleavage is increased as well. So the net result is that you have a normal IGF intact and C-term ratio. Nothing happens. In patients with autosomal dominant hypophosphatemic rickets, the cleavage is not working, and so you have a little bit increased FGF23 levels. But if you have both, you have iron deficiency and the cleavage defect, then you have increased synthesis and decreased degradation, and then the patients get symptomatic. That means, on the other hand, patients who are getting symptomatic with autosomal dominant hypophosphatemic rickets usually or often are iron deficient. And this is nicely shown here in this trial, where the patients with genetically proven diagnosis had elevated FGF23 levels, and then they get iron replacement therapy, and you see that the FGF23 levels go down between 20 and 80%. And of course, ferritin goes up, and you see that the serum phosphate gets up, and more important, you see that alkaline phosphatase is going down. So the main first step in those patients is late diagnosis and iron deficiency, and it's rather easy to treat. And there are other rare causes of FGF23 associated hypophosphatemia, like fibrous dysplasia, and some patients are easy to diagnose because they have cutaneous skin lesions, like the cutaneous skeletal hypophosphatemia syndrome. And if a patient presents after the age of 2, 3, or 5, or 6 years, you always have to make sure that it is not a tumor-induced osteomalacia, especially if the panel diagnostics, genetic diagnostic, is negative. Biochemically, you can't differentiate that, but the patients often have very, very severe symptoms, and there's sometimes a discrepancy between severe bone pain, but biochemically not so much changes. And it's not easy to diagnose. It's mesenchymal tumors, and you need a thorough workup, and you really need to check mostly with scintigraphic methods to find the tumor. If the tumor is removed, then everything is fine, but sometimes the tumor is not completely removed, and then it comes back. So we come back to a second case. It's a 2.5-year-old male with a negative family history of bone disease. Again, both legs. That's the X-ray. Here on this side, you find something. And he walks with a rattling gait. He tires easily. He's a stroller and has a reduced height. So the study results are phosphate, lower H alkaline phosphate elevated, PTH 7, 25, normal range, 125, normal range, C-term elevated, and phosphate wasting. And please notice you have a normal urinary calcium creatinine ratio. So the PTH is normal, so it's a phosphopenic rickets, and you have low TMP over GFR, and you have elevated FGF23. It's probably an FGF23 mediated disease. And we are here, and the patient was then tested genetically, and it was a PEX gene mutation. So it's a sporadic case of XLH. Next patient, number 3. Is almost 4-year-old girl. She has renal stones on mom's side of the family. Renal stones, very important. She's short, absolutely. She has bowing of legs, and she trips and falls when she's running. The teeth look normal, and she has a normal hearing otherwise, but however, she's rather young. Now we come to the lab results. You have calcium is normal, phosphate is normal, alkaline phosphatase elevated, PTH normal, 25 normal, 125 slightly elevated, TMP over GFR decreased, and the urinary calcium creatinine ratio was checked several times, and it was elevated. And however, on the renal ultrasound scan, there was no nephrocalcinosis or stone. So PTH is normal, so it's probably phosphopenic rickets, and you have this combination. Any thoughts in the chat?
So far, no suggestions.
Okay, so it looks a little bit like the patient we just had, the case number 1, doesn't it? Okay, so let's go. So so the colleagues made a thorough genetic analysis, but there was no mutations, especially also on SLC34A3. So the NAPI receptor was also fine. There was no pathogenic mutation. And Then the patient was transferred to the nephrologist. It's not that nephrologist is better here, but it's sometimes in patients like this, it is a patient with cystinosis. The Fanconi syndrome at the beginning is rather subtle. So the patients may have hypophosphatemic rickets, but they don't have glucosuria at the beginning. They may have even don't have a generous aminoaciduria. So you always have to thoroughly check the patient. And in the next, I think it took 2 weeks or 3 weeks when the patient showed up in our unit, we noticed that the patient had full-blown Fanconi syndrome and had a patient and nephropathic cystinosis. This just makes clear once again basic clinical assessment, which is usually not expensive, is very important at the beginning, because for this patient the initiation of cysteine depleting therapy was really delayed in the end by several months. So, and Francesco knows best from us that this is not good for the patient if the patient gets delayed diagnosis. So we are here with the Fanconi syndrome. So that's the diagnostic workup, which you can easily look up in the review. I just put in here the basic stuff you want to check. Of course, it depends on your setting. I just put here everything. So you may think about if you need FGF23, if you do a genetic testing anyway, and you may also wait until you measure 125 because it's more expensive. You may do this in the second round, but spot urine for this, it's good to do at the beginning. And of course, estimated GFR and TMP over GFR is always good. And of course, you need genetic analysis to confirm the diagnosis, especially in patients with a negative family history. So thank you for your attention, and I would like to remind you there's a next webinar. It's during the ERKNet meeting in Venice. It's about patient involvement from Mats Bolz-Johnson on the 22nd of April, and then on thrombotic macular angiopathy in May. And then in the end of May, there's a nice introduction into the biostatistical approaches in clinical research of rare diseases. And this is my last slide. You can follow up this on social media. Thank you very much.
So thank you so much, Dieter, for this wonderful presentation. I think that you certainly are, in our community, the biggest experts in these diseases, and it's always enlightening to listen to you. So the session is now open for questions, and we have a first question from Dr. Hassan Magin. That he thinks that you didn't mention amino acid glucose in the urine the last case. Do you want to comment this? I think there was glucose actually.
Yes, this was a real case, and amino acid and glucose were increased when the patient showed up in our clinic, but in the clinic where the patient was before, they didn't check it. Yeah. So it's not, I will not tell that we are the brightest. I will just tell you. And the funny thing is, we've been called by them asking, and then we'll say, oh, it's probably hypophosphatemic rickets with hypercalciuria, because we couldn't think that they didn't check all the tubular markers. And that's the difference if you get a call or if you see the patient. So when the patient showed up in our clinic, dipstick, blah, 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 everything was done, and a blood gas analysis was done. In the other outpatient clinic, they couldn't do a blood gas analysis. So, of course, the colleague who made the question is absolutely right. This should have been done immediately at the first visit. Absolutely, absolutely right. But this is just a real case showing you that sometimes it's misleading.
Would you care to comment on proteinuria and low molecular weight proteinuria?
The low molecular weight proteinuria is usually increased in Fanconi syndrome, That's for sure. But the patients also may have macroalbuminuria as well.
Absolutely, absolutely. So, so always, Dr. Hassan Magini is thanking you. He just mentioned that even the serum bicarbonate.
Yeah, but I have, you know, I remember, I think it was not the last case with cystinosis, the case before. It was a few years before. We had a patient who had just hypophosphatemic rickets, no glucosuria, and bicarbonate was normal. And then I said, and then I said, well, that's hypophosphatemic rickets. And then I said, he's pale and he's so blonde. And it must be cystinosis. I said, no, there's no acidosis, nothing there. And then it was, of course, cystinosis, because sometimes at the beginning, it's not a full-blown Fanconi syndrome. And this may be really misleading. So you need amino acid testing and maybe check twice, because it's always a cause. If you are at the early stage, it's maybe misleading.
Okay, wonderful. So please, if you have questions, send in your questions. So one thing, Dieter, is so can you tell the audience and yourself, when do you think that you can really see bowing of the legs, and what are your parameters to say that the bowing is no longer physiological in an infant?
I'm extremely uncertain about this, because especially in the babies, they have a lot of fat around, and sometimes I think, oh, it's not really really bowing, but they're not really walking exactly. It's really bowing, and you know, I let them lie down and measure the intermalleolar distance and measure this. But even so, sometimes I don't get it, and I just get it on the X-ray. And if the children get older and they are walking, then you see it best in the walking, when they are walking. You need it. Sometimes I don't see it when they are just lying down. I let them walk, and as soon as they walk, then they have this waddling gait, and then it's more easy. So I really prefer the functional test, and this is also for me the most important test in clinical practice. So if the XLA patient comes into my room with a diagnosis, the first I open the door and say, let's go outside, and then I let them walk and run and see, and then I see the progress. And if they are running like this, like athletics, then I know it's fine. But if they're like this, then I see and that's for me the most sensitive thing, because with my eye computer, I have to confess, I'm not very good.
And this is actually the purpose of my question, is that until they don't walk, it's extremely difficult to make the difference. And even phosphate, if you don't check the levels with the normal values, it's very difficult to make the diagnosis.
And in the first 3 months of life, biochemically to diagnose XLH is extremely challenging. And I think we nowadays mostly do this by genetics. And because then it's phosphate lower rich, alkaline phosphatase is not up already, and then you have a upper phosphate at the upper normal range. So what I usually ask the parents to come when the children are a few weeks old and something, and then we go for genetics.
Right. So so Dr. Husamagin, again, thank you. And he asks you, as an adult nephrologist, he's curious about your take-home messages. So which take-home message do you give to an adult nephrologist?
So XLH and all these diseases I just explained to you are causing rickets, and rickets is gone. We made it because the growth cartilage is gone. But what persists is osteomalacia, and many adults with these diseases I just shown to you may have significant disease activity ongoing due to ongoing osteomalacia and may require medical treatment, although growth is finished.
Wonderful. Maybe I will ask you a last question, and so then we can close the webinar. So with the phosphate transporter variants, we often see that phosphate levels are unexpectedly, at least in theory, not in theory, but at the first approach, we are surprised that often these patients do not have hypophosphatemia. So how do you explain this?
I think there are compensatory mechanism in the kidney. So it could be compensatory mechanism, and at least for NaPi2a, we believe that the importance of this phosphate transporter is more important in early life. So at later stages, it goes away, but it's usually in the lower normal range. And I think in our survey, only about 27% of the patients with compound heterozygous or homozygous NaPi2c defects had profound hypophosphatemia. So it does not exclude if you have a normal phosphate. So in any patient with nephrocalcinosis, hypercalciuria, it could be a phosphate transporter defect, and I would not care on the phosphate levels for those patients. That's even it's called phosphate transporter defect. It's not the main leading biochemical finding. It's nice to have if it's low, but if it's not low, it doesn't mean.
And usually the PTH is in the low range or even suppressed.
Yeah, you're right.
I ask you the question because it's sort of counterintuitive. You have a phosphate transporter which is missing, and yet you do not necessarily have hypophosphatemia. I was thinking that it would be interesting for the audience to just make this point first. Thank you very much.
You're right, Francesco. Maybe the people did not get it. You just mentioned the most important thing. Thank you for reminding me. So the most important biochemical characteristic is that these patients have suppressed PTH.
Yeah. So I think we have no more questions. Again, this was a wonderful talk. I think that, and you know, one of the at least for me, one of the nice thing about these diseases is that the physiopathology is very clear, and if you follow the physiopathology, most of the time you can at least restrict the diagnosis into subcategories, and it's always very it's always very nice, and it's not the case for all the diseases.
And correct diagnosis matters. If you do not make the 100% correct diagnosis and you start a medical treatment, you may harm the patient, like the case number 1. So it makes it's nice with the pathophysiology, but you have to do it correctly.
And I will invite the audience. So Professor Haffner wrote 2 wonderful reviews, part 1 and part 2 on rickets. And I think that all the information is there. So if you're interested in these diseases, please go and read these articles. And thank you again, Dieter, for this wonderful.
Thank you very much.
Presentation. And see you next time with the next webinar. Thank you.
Thank you. Bye-bye. Have a lovely evening.